Dr. Subash, please.
Respected chairpersons, respected senior members of the faculty, and dear colleagues. So the topic is regarding the management of CBD injuries in laparoscopic cholecystectomy. When things go wrong, what you can do. So regarding laparoscopic cholecystectomy, it is one of the most commonly performed abdominal surgeries to treat gallbladder-related diseases worldwide. It is to the tune of around 750,000 cases per year from the data from US. So as the number of cholecystectomy has increased, the number of bile duct injuries has also increased. So the incidence is supposed to be around 0.3 to 0.6%, which is historically 3 times higher than the open cholecystectomy. So there are several risk factors described for bile duct injuries in laparoscopic cholecystectomy, ranging from anatomical variations, patient-related factors like obesity, prior surgery, CLD, and bad gallbladder pathologies like acute cholecystitis, contracted gallbladder, surgeon-related factors like inexperience. But the major and the most common underlying reason in all these causes are misidentification or misperception of the normal biliary anatomy that leads to the bile duct injury. So around 25 to 40% of the bile duct injuries are recognized intraoperatively, and rest of the cases are reported post-operatively, either in the immediate post-operative period or in the late post-operative period. In the immediate post-operative period, it can either present as incision draining bile, or if you have already kept a drain, the bile draining through the drain, or as it can present as an acute abdomen with a biliary peritonitis or a bilioma, or in long-standing cases as a benign biliary stricture, which will present as obstructive jaundice. So suppose if the bile duct injury is happened and it is detected intraoperatively, what you can do as a surgeon. So the surgeon first must decide whether he has adequate HPB training and expertise, and it is not only the expertise, but he should have the adequate staff pattern and resources to repair the injury. That is also very important. So these two factors should be there, and if he decides he cannot safely repair the injury, then ideally no further dissection or conversion to laparotomy should be performed. That is the ideal thing. So what you should do is just place a good drain and come out. So don't try to complicate it, just place a good drain and come out. That should be the dictum. Patient may be evaluated in detail later, and either to transfer to an institution where expertise is available or call for the help of an HPB surgeon. So this should be the ideal thing. If you don't have an expertise, or even if you have an expertise, if you don't have adequate staff pattern and resources to do an HPB surgery, then this is the best thing. So suppose if you have adequate resources and the HPB training, so these are the situations that can be dealt with. One thing, you have clipped the CBD or CHD and you have identified that you have clipped it and not cut. So then what you can do is just simply remove the clip and complete the surgery. So that clipping might produce a bit of ischemia, but that can be dealt with later. So if it is a minor bile duct injury, that usually happens from cholecystohepatic duct or the subvesical duct or a small segmental duct, that can be easily clipped or sutured. That will definitely produce an asymptomatic atrophy of the segment of the liver. That is okay. So if it is a major bile duct injury, then I have already discussed, it should depend upon the expertise and resources. And if it is only a partial injury, like a lateral injury, and the expertise is available, what you can do is you can repair it over a T-tube or a biliary stent. But nowadays, people are usually putting the biliary stents rather than the T-tube, because keeping a T-tube in a normal-sized bile duct is usually difficult and it can aggravate the injury. So nowadays, it is usually done over a biliary stent using a 4-0 or 5-0 Weichel sutures. And if it is a complete cut, then the ideal thing is to convert it into a wide Roux-en-Y hepaticojejunostomy at the hilum. That is the usual procedure. A primary end-to-end anastomosis is also described, and in many transplant centers, people are doing duct-to-duct anastomosis, but it carries high risk of strictures. So a safe option would be a wide Roux-en-Y hepaticojejunostomy at the hilum. So this is in a nutshell. So just assess the local resource availability and HPV expertise. If it is not there, just keep a drain and refer the patient. But if the expertise is available, then you just classify whether it is a minor duct injury or major. Minor duct injury, you can safely suture it. Major duct injury, you have to do a Roux-en-Y hepaticojejunostomy. So if it is associated with vascular injury, it is a different ball game, and that is going to be very, very difficult unless you have sufficient expertise. So this is regarding the bile duct injury detected during the surgery. If it has got a delayed presentation, it can present either as a controlled biliary fistula when you have a drain, or an uncontrolled biliary fistula where patient presents with acute abdomen, either because of a bilioma or a biliary peritonitis, or later patient presents with benign biliary stricture, that is because of obstructive jaundice. So in these situations, you need to have a detailed evaluation, initially using ultrasound abdomen and then either a CECT abdomen and MRCP depending upon the situation. If you have a bilioma or peritonitis, CECT is the ideal investigation, whereas in benign biliary strictures, it is the MRCP that is usually being done. And you have to classify the injury. There are a wide array of lot of classification systems are available, ranging from Strasberg classification, then Bismuth classification, Stewart-Way classification, lot of classification systems. But usually what in a clinical setup matters is mainly the Strasberg classification and the Bismuth classification. So what you generally do is you divide it into a minor bile duct injury and major bile duct injury to remember correctly. And if it is a minor bile duct injury and if it is a bile leak through the drain, it is usually a cystic duct leak or subvesical duct leak. You can do a non-operative management. You can try a non-operative management initially. And if it worsens, you can do an ERCP and stenting, sphincterotomy and stenting. That will settle the issue. But if you have got a bilioma or a biliary peritonitis, you have to first drain that collection, control the infection, then go for ERCP and stenting. That will settle the issue. But if it is a major bile duct injury and the patient presenting with biliary peritonitis or a bilioma, then definitely you have to do a percutaneous drainage. Here the difference between the minor and the major bile duct injury is you don't have the biliary continuity there. So you have to wait and give sufficient time for the healing to happen, and then you have to do a wide Roux-en-Y hepatic jejunostomy at the hilum. That would be the treatment. So whenever you talk about biliary injuries, you have to keep in mind that there are a lot of medico-legal issues associated and the litigation claims. So these data, so you can see that it is around $1 million US. That is the annual cost of litigation related to bile duct injuries alone in US. So it highlights the importance of preoperative informed consent and to include the possibility of severe complication like bile duct injuries, not in every case, at least in cases where you anticipate difficult cholecystectomies. So there are several efforts, ongoing efforts to improve the safety in laparoscopic cholecystectomy that has been going on. Even the SAGES has launched a new initiative to improve safety in laparoscopic cholecystectomy that is called the Safe Cholecystectomy Task Force. So they have come up with five most important things, that is establishing the critical view of safety. These are the 5 important things. Understanding the relevant anatomy, appropriate retraction and exposure, knowing when to call for, always call for help if your procedure is going in a bad manner, and recognize the need for conversion. The conversion is not a failure of the surgery. So if you find that you are going to make a bile duct injury, it is better to convert rather than digging on with the laparoscopy alone. And you have always to have a bailout procedures like subtotal cholecystectomy and fundus first technique in difficult cholecystectomies. So now there are newer modalities that is coming up, like intraoperative ultrasound and near infrared fluorescence cholangiography, that is the ICG cholangiography. And these techniques will help you in identifying the bile duct and the gallbladder if you anticipate these difficult cholecystectomy in the prior instance. You can see that the bile duct are clearly visible in ICG cholangiography in this particular video, and already the Falcon trial is going on. The result has come up and it shows very good results. And these newer modalities might reduce our future chance of laparoscopic cholecystectomy related bile duct injuries. Thank you.
Excellent presentation. I have a doubt. Do you routinely use ICG in your center, or is it used only in complicated cases?
No, I don't have an ICG setup in my center, but it is coming up in a big way, and most of the centers are now, the new stores setup is with ICG inbuilt system, and people are started using it, and probably in near future most of the centers will have the ICG.
Okay, as you aptly put, I think you should seek the help of seniors or juniors who
Yeah,
go over,
colleagues, yeah,
and always it is better to get the help of a cholecystoscope rather than a cholecystoscope or a cholangioscope.
Yeah, well said, sir.
How will you manage a clip across, applied across the CBD? Usually that will be diagnosed late. Patient will be developing jaundice. There won't be any leak. So how will you manage it?
So that will come, the patient will be presenting later in a phase where the usual presentation will be as an obstructive jaundice. So initially the problem is in benign biliary strictures, if the associated bile leak is also there, in some cases there won't be any bile leak. In such cases, what we usually do is you give sufficient time for the healing to happen there and then go and repair. That is usually by doing a Roux by hepatic jejunostomy. That also needs to be higher up in the hilum. So we do a hepatic jejunostomy at the hilum. That is the treatment.
I am asking about the timing. Timing of surgery.
The timing is always controversial. There are two schools of thought. One, if there is a definite infection around, if there is a biliary peritonitis or a bilioma, definitely you have to wait for minimum 6 to 8 weeks after draining all the collections, after the entire infection to subside, and also the inflammatory response to settle. Because when you take bites, it can cut through. That is the problem. So you give sufficient time, minimum 6 to 8 weeks. Suppose if a benign biliary stricture has happened without any of the collection, it is just a clip across, and there is no evidence of infection, and there is not much of inflammatory reaction. There are reports and people doing it as early as 2 to 3 weeks after the surgery.
If it is a complete transection, are you justified in doing an end-to-end and or a T-tube primarily?
Yeah, because as the transplant exposure increases nowadays, because the people are doing more and more exhaustive HPV procedures, there are certain centers where if the end ischemia is not much there, if the ischemia at the end is what it matters, if it is not there, and if it's okay, then the people are doing end-to-end anastomosis, but definitely the risk of stricture is higher. And a safe procedure in most of the centers would be hepatic jejunostomy. That is the ideal option.
Thank you, Subash, for the excellent presentation. Thank you.
Thank you very much, sir. Thank you to all the chairpersons and speakers of the session. Come to the end of the session.